Okay, everyone, thank you for joining us. We'll give attendees a few minutes to join into the room. Thank you to all of you who joined early and were in the waiting room. We are really excited today to be bringing another telehealth webinar, a CTRC webinar. Today's session is on the digital health update. This is part 2. If you're looking for part 1, we'll make sure that you have recordings from both sessions if you're here today. But this is part 2, Medicare updates in the physician fee schedule for calendar year 2025. The next slide, a few reminders as we get started. CTRC does not provide legal advice. Everything that we're going to talk about today is for informational purposes. Any products or services that may be mentioned, there is no financial interest or arrangement or affiliation that we need to disclose. As always, you can find CTRC's grant information on the bottom of the screen on this slide. We are wonderfully supported by the HRSA Office for the Advancement of Telehealth and also from the California State Office of Rural Health. A few tips for all of our attendees joining us today. You have been muted and your cameras are off, but we would like this to be an interactive learning session. So we're going to encourage all participants to open up the chat and the Q&A function, and please chat with us. Let us know your comments and your questions throughout the session, and we'll have a few minutes at the end to discuss with you and make sure we follow up to provide the information. We'd also like to remind you that this session is being recorded. So again, if you want to revisit this content or visit part 1, we will make the recording available to you. All right. I'll introduce our speaker, who is Sylvia Trujillo, the Executive Director of CTRC. She's going to be doing today's presentation on part 2.
Great. Thank you, Aislinn. I just want to give a acknowledgement to the team that has prepared this content: Mariah Getch, Aislinn Taylor, and Jan Leto. The physician fee schedule, as all of you undoubtedly know, is annually issued around November or early December. It becomes effective on January 1, and we provided already a part 1 session. Would like to thank Robert Jaron, who laid out changes as they relate to remote monitoring and management of patients. Specifically, he provided very detailed information as it relates to remote therapeutic monitoring. At the end of this 30-minute session, I'm going to do a quick recap of those key points that Robert really laid out. It's a complicated area, and our job is to simplify and make it readily accessible. So today we're focused on telehealth, so not the remote patient monitoring and management pieces, but telehealth. So we're going to move to the next slide. Okay, so during the COVID-19 public health emergency, a number of flexibilities were put in place. We have enjoyed those flexibilities, and these apply to Medicare. We're talking Medicare patients, and there was flexibility that allowed them to receive services in their home. They did not have to be so previously, just so everybody remembers, before the pandemic, there was only a few services where a patient could be in their home. These were hospice related and ESRD related. But during the pandemic, the federal government said, we're going to waive that statutory requirement that they be in a qualifying location, which typically would be a doctor's office, a hospital, or some other facility. And they said they could be in their home. So that was a flexibility that we've been continuing to enjoy. There was also flexibility around the geographic location, namely telehealth services statutorily have been limited to essentially rural geographic locations. That too was waived, and we've been enjoying that. And in addition, we've had flexibility around the use of audio-only communications for certain telehealth services. And in the context of behavioral health, This is a little bit of a wrinkle. It was a service where Congress thought they were doing everyone a favor by saying that we're going to cover permanently behavioral and mental health services, um, because all the rest of these were temporary flexibilities that required an act of Congress to make permanent. So they went ahead and did that for behavioral and mental health, but they gave us a little bit of a extra requirement on top by saying you can you can have all of these flexibilities that I just detailed for you, but you have to have an in-person visit with that patient within 6 months of this initial visit and then annually thereafter. And that particular requirement also has been waived during this flexibility period. And then last, there's been a limited number of clinicians that were eligible for coverage of their services by law, and that was waived. So just wanted to remind everyone that these are the flexibilities that have been in place, because as we move to, let's go to the next slide, the Medicare physician fee schedule, those flexibilities are going to fall away for the majority of patients, except for those who are served by FQHCs and rural health clinics. So, um, everything that I outlined, getting a service in their home, being somewhere other than a rural location, an expanded category of providers. If your patient, um, if you're not an FQHC or RHC, then you can still offer telehealth if you're in a qualifying rural location, um, and the patient receives the service in a qualifying rural location. But the flexibility about them being in their home, that falls away. So this is complicated. We're going to create some additional tools so it's easier for you to see. And I will hasten to add that there is credible information coming out of DC that Congress may in fact act to extend these flexibilities at least one more year for everyone. But for right now, CMS has the authority to extend that for FQHCs and RHCs for one additional year. So let's move to slide 8. So what does this mean for FQHCs and RHCs? So as you can see here, you can continue to bill for this service. In addition, you are able to use audio and video with regard to direct supervision. So this is a supervision flexibility that you also have expanded flexibility on. And the requirement for the in-person for mental and behavioral health is also extended. And I just want to remind everyone that as we move to the next slide, that these flexibilities also extend depending on the service you provide. So, if your patient is receiving ESRD services, the requirement that they be in a rural location does not apply. So this applies for both rural and urban patients. So that's a service where that will permanently be available. Congress has acted in the past and has made that permanent. Telestroke is another service where there's been a permanent extension of flexibilities, and you can see laid out here the specificity with regard to that. And then with regard to substance use disorder, similarly, there are flexibilities that have been permanently extended with regard to the originating site, and that's the location of where the patient is receiving that service. So these were not impacted by the final rule, but we are outlining this so that when you hear the telehealth flexibilities are going away, you do not forget that Congress, in very specific circumstances, has acted for certain services to extend those flexibilities. So let's move to the one of the bigger flexibilities, which on this slide you can see with regard to behavioral health. This so if you're in a rural area, you're an urban provider, and you are interested in providing behavioral health services, you can continue to do so for a patient in their home. You don't have that geographic restriction. You have the discretion to use audio only. And in the context of FQHCs and RHCs, they can serve as a distance site provider. This is significant. This is important because, as many of you probably know, a really significant portion of telehealth services, post-pandemic, the lion's share of those telehealth services have been for behavioral health. So this is not a small exception to that broader rule that the flexibilities fall away. We know for behavioral health, they do not. So moving to the next slide. Now, I just want to make sure that everybody is level set with me and everybody understands that these provisions apply to FQHCs and RHCs that can have all the flexibilities we talked about, without the limitations on where their patient is geographically or where, like, in their home or a facility. But these also apply to providers who, let's say, are in a geographically qualifying location, so a rural location, and their patient is receiving the service in a qualifying facility or site. So these also apply. But if you think about it as a Venn diagram, there are a certain number of services that everyone, FQHCs and RHCs, can provide all the services. Everyone else can continue to provide services to patients as long as they meet those other prerequisites. And then you get these additional flexibilities with regard to audio only, as well as this really important flexibility with regard to, and it's not really a flexibility, it's a really essential requirement with regard to provider location reporting, where, if you recall, normally providers have to report their physical address at where they're at delivering the service. But that's a problem if you have a telehealth provider working from home. And so you want to ensure their safety and their privacy. And so this has been a rule that has been long advocated, that it's really where they are currently enrolled with regard to their practice location. Another really important one is this policy with regard to frequency limitations associated with subsequent inpatient and nursing facility visits, as well as critical care consultations. These are an example of where CMS has had the discretion to do the work that I think we all agree is really critical to continue to maintain access. Okay, so let's talk about direct supervision. And I'm going to just take a minute. I think we have some questions. I do want to make sure to get through all of this. I'm going to ask Aislinn if you can call out some of the questions, because I can't actually see the...
Yes, Lisa is asking, and perhaps this will be mentioned in your presentation, how do Medicare changes transfer or not to Medi-Cal?
Okay, so they don't transfer. They're very distinct government programs. And so we are covering Medicare. We do have an announcement at the end about a recent notification by Medi-Cal about their coverage, but I just want to remind you all that Medi-Cal has permanently extended their coverage of telehealth services. So if there's a panic that you think we're talking about Medicare and Medi-Cal, let me tell you, don't be panicked, because on the Medi-Cal side of the house, there's coverage for telehealth. Does that address your concern? Yes, they will, Maya. So, okay, so we're going to keep moving, defining direct supervision. This is a sort of perennial issue around resources and staffing. And so previously, direct supervision had been a pretty draconian requirement in the context of telehealth, particularly during the COVID-19 pandemic. The ability to directly supervise folks in person was quite a challenge. And so this particular requirement, if you move to the next slide, there was very liberal release of these requirements. And so you can see here through 2025, direct supervision is again being permitted through remote supervision. As long as it's real-time audio visual. So it can't be just audio. Just want to make sure you're aware of that. Also this idea of, immediately available. And you can see we also have here, it's very clear that it can't be asynchronous or audio. And the permanent extension of this for certain services has also been laid out that are low risk by CMS. And you can see that CMS is continuing to evaluate this issue. So I'm going to go to the next slide. And you can see here that general supervision requirements are now permitted for certain OT and PT activities. So if you're offering those services, this is an important point of flexibility. We're going to move to the next slide. Opioid treatment programs. This is one of those areas where there's an exception to the general, more restrictive view, or reverting back to the statutory language. So you can see here that there is a clear acknowledgement that we have a public health crisis with regard to substance use disorders and addictions. And so there is an alignment here between CMS policy, the DEA, which regulates prescribing of controlled substances, including treatment substances such as methadone and buprenorphine, and SAMHSA, which is an agency within HHS that focuses on um, substance substance use disorders and other mental health issues. So you can see here a number of provisions that would support addressing this condition and enhancements of policies to try to scale capacity because we have a shortage of substance use disorder clinicians. Okay, so let's move to the next slide. So I will just touch very lightly on this particular slide. It really concerns the remote therapeutic monitoring, but could include other digital health services. This particular policy change, the advanced primary care management services, these are new codes. And they're for folks that are in certain alternative payment models or who are in the MIPS and VP. So it's a really limited category of individuals that could benefit from these codes. And these were covered previously in our first session and laid out in great detail. So a couple of sort of late breaking items that came in just recently. CMS has clarified that effective April 1, home health agencies can submit claims for telehealth even where they overlap with inpatient skilled nursing or swing bed claims. So this is important as we think about sustainable models as patients are aging at a very high rate. How can we ensure that both hospice and hospital services can be sustainably provided? And the details are very beautifully laid out here. I'd like to shout out to either Jan or Mariah. They do a really terrific job in helping to visually understand this content. Now, We have about 10 minutes left, and I'm going to give acknowledgement to Robert Jaron here. I may ask him to come off mute, but we just want to recap really quickly, give you some tools so you can see the current environment for remote patient management here. And there's two flavors of remote patient management. There's remote physiological management and monitoring, and there's remote therapeutic management and monitoring. And we've laid out here for RPM, which, we're looking at addressing diabetes, where you're monitoring um, uh, blood sugar readings. You could be monitoring weight. You could use RPMs for cardiovascular disease. It's very straightforward what the payment and reimbursement is and the coding for these services for setting up the devices and doing patient education, the professional service components, the additional time, as well as the device supply. And I just want to contrast that with the remote therapeutic monitoring and management. You can see it looks very similar when you look at initial setup, professional service, but then it takes a turn with regard to device supply. And depending on your therapeutic intervention, if it's respiratory, musculoskeletal, there is reimbursement. But for cognitive behavioral, with regard to the device supply, there is not currently. Darren, I want to make sure I said that right. I don't know if you're able to come off mute. I just want to make sure that last part is a correct statement of where we are currently.
You mean as far as device supply for kind of, and by the way, thank you, Sylvia, and I'm glad to be here, and thank you for recapping these. But your point on the device supply of the three splitters, as we call it, for remote therapeutic monitoring, which would be the three individual supply codes versus the one lumper code, which would be for physiologic, the one device supply code for physiologic. Is that correct?
Right. And I just want to make sure that the device supply code for cognitive behavioral, I think that
That is
went to the
correct.
contractors and it was
That
zero.
is correct.
And I wasn't
Yep.
certain if they were going to revisit it in 2020.
We Yeah, we don't know. As far as my understanding is that that code over the past 2 years that it has been at the contractors for contractor pricing has only been billed a few dozen times. I am not aware that any contractor actually ended up paying those providers that reported the use of that code. That is strictly upon the contractor as to whether or not they do want to or do not want to pay for that code. That's one of the oddities of the new code, that has been now finalized for supply, which you do not have on this page. And I don't know if you're going to present that one as well.
Yeah, we're
That
going
one
to,
also was sent to, yeah, that
yeah,
one was also
well,
sent to contractor pricing, and unsure whether or not that one will get paid by a contractor or not.
yeah. And so we're going to thank you for going ahead. This is so what Jaron is talking about is that we do have this, and if you were at the last session, you will have heard about this. We do have this curious development where CMS has developed some new codes for digital mental health treatment, and you can see them here. These, and we compared them to the remote therapeutic management codes for cognitive behavioral health. And we wanted to compare them so that you could see what the difference and what the similarities were between these codes. So initially we thought it says digital mental health treatment. We thought maybe it was bigger than cognitive behavioral, but as Jaron helped demonstrate, it turns out the only devices that have been cover behavior cognitive behavioral treatment. And you can see that in the orange. Um, and Jaron, I did want to ask you a question. It seems like they combined in their description on the right side for digital mental health treatment, they combined the setup with the supply of device.
That's correct. So instead of having two separate codes under as CPT has 98975 and 98978, two individual separate codes. The CMS proposal combines those two into just one code. So you have setup and education as well as a supply of equipment.
And so it looks like they didn't value that like the ability to value both will go to the
Setup and education.
contractors, right? And so
Yeah.
it means like
Yeah.
you doubly don't get paid.
Correct. Yeah, that's correct. And
So
I do want to clarify something that's not on this line, but the next line, you have the professional services under the new HCPCS codes as zero valuation. I just want to make sure that people know that those arrows that you have put in there are very important because those arrows are crosswalked RVUs to those new codes, which means that they have the exact same valuation and coverage and payment as the existing CPT codes, which are on the left-hand side.
yeah, so probably for everyone before we send these out, we will add that clarification so that folks don't think it's a zero. 99091. So Jaron, can you remind me if that one has been retired?
It has not. 99091 continues to be active and covered and paid. It is not necessarily for remote physiologic monitoring. It's really for collection and interpretation of physiologic data. It has separate requirements that are distinct from 99457 and 458. So I would encourage that caller to look into that code more deeply, but that code does continue to be valued and is separately covered and paid.
Great. So I'm gonna have us move to the last slide, I think, in this section. And just I want to go back up really quickly, one more above. Just a reminder that for FQHCs and RHCs, you can use, well, you are covered for RPMs and RTMs, but there is a requirement now, instead of using the catch-all G0511, you are required to use the actual codes we just covered, the CPT codes, and presumably if you decide you want to do digital mental health treatment, those codes as well. So there's some difference in reimbursement amount. We'd love to hear from folks about what they are experiencing, because one of the things there is a concern is that may be too low. So we have 3 minutes. We're going to go to the next slide. Now this is Medi-Cal. So I just want to underscore, we breezed past the slide before it. The slide before it, we're now transitioning away from Medicare to Medi-Cal. And the next slide, Medi-Cal has announced in a public meeting that they are now going to cover e-consults for primary care providers. So the specialist was covered, but not the primary care provider. We are awaiting additional details on this policy change, but it is seismic, it is significant, and it is very, very important. Okay, with regard to the DEA, we also got some clarification with regard to next steps, and it looks like they're punting the ball for another year. And the flexibilities around having that initial in-person before you start prescribing is essentially waived until December 31, 2025. So you were always able to prescribe, or you were able to previously to prescribe via telehealth controlled substances, but you were required to have an in-person visit first. That was waived during the pandemic, and that waiver has now been extended. So I just want to thank everyone here today. And just remind folks we have some additional resources, including a digital health service payment guide that we'll be updating with all this latest information. We have a healthcare AI toolkit, and we'll be doing a boot camp that we'll have more details on. And if you want to stay connected, please follow this this code, and you can follow us. And I just want to thank Robert for the cold call. We appreciate you jumping in and helping us out, and the team for the great work that they've done. Did I miss any questions?
We do have just a few questions we can run through. Confirming when it comes to, I believe, general supervision, is this model appropriate? Can a resident be at the patient bedside with a supervising MD beaming in via telehealth?
Um, I do, as long as it's two-way video interactive. And if I'm incorrect, we will send that out in the slide deck, but that is the gist of the flexibility. It could not be audio only.
And then we'll run through the last two questions quickly and make sure they're sent out in the materials. There's a question. It is looking like we are seeing commercial plans rolling out speech therapy and occupational therapy into physical therapy, and then stating that there is no telehealth coverage for physical therapy benefit. Is this something Medicare is or may move towards?
It's unusual for Medicare to copy insurers. It's normally the other way around. But I'm glad you flagged it because it's something that we can monitor for, and we'd love to hear more about your experience if you would be willing to email us, because again, we're looking for trends and we're trying to keep people apprised.
Great. And then last question is from Lisa. Do you have information on whether CPT code 99091 can be used for RPM?
Oh, so Aislinn, we actually filled it that way.
Okay, great. Awesome.
Okay, awesome.
And that is it. Thank you, everyone, for submitting your questions.
We appreciate you, and we hope you appreciate the shorter format. We're moving very quickly. Yes, Kristen, we are waiting for that information. Kristen asked for a link to the Medi-Cal announcement. Aislinn attended a conference with a deputy director from the Department of Healthcare Services. It was publicly messaged out on LinkedIn. So we are awaiting the actual link that explains the details around the coverage. As soon as we have it, we will send it out on our social media and we'll include it in our newsletter. Again, thank you all. Hope you appreciate the shorter format. We are hoping to pack a lot of information in a little time because we know you're very busy. Be well. Thank you.
Yeah.